Hi, so today I'm here to discuss to you about the aortic regurgitation, the aortic stenosis, and septal defects such as the atrial septal defect, the ventricular septal defect. So in each topic, I'm going to discuss about what the disease is all about, its pathophysiology, its clinical manifestations, its different kinds of diagnostic procedures, treatments, medical management, surgical management, nursing diagnosis, and prognosis. So I hope you keep watching and listening to my discussions. Hi, so today we're going to discuss about the aortic regurgitation. Aortic valve regurgitation or aortic regurgitation is a condition that occurs when your heart's aortic valve doesn't close tightly. Aortic valve regurgitation allows some of the blood that was pumped out of your heart's main pumping chamber or left ventricle to leak back into it. So some causes of the aortic regurgitation includes aortic root dilatation, secondary to connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, infectious diseases such as syphilis. Congenital bicuspid aortic valve is the most common cause of aortic regurgitation. It is autosomal dominant. It is also incomplete penetrance. It is also a significant family history of cardiac deaths that leads to clue towards clinching diagnosis. So in younger patients, it presents with isolated aortic regurgitation due to valvular leaflet abnormalities or aortic root dilatation that can progress to the formation of aneurysm, aortic dissection, sudden cardiac death. So in older patients, it can also cause aortic stenosis. It can be also seen in inflammatory diseases or conditions such as rheumatic heart disease, infective endocarditis. Due to insufficiency of the aortic regurgitation, the black flow of the blood into the left ventricle leads to the increased left ventricular end diastolic volume, which leads to compensatory myocardial hypertrophy and left ventricular enlargement, thus initially maintains the stroke volume and the cardiac output. But the increase of the left ventricular size that brings the ventricular apex close to the chest wall that causes pounding sensation and comfortable awareness of heartbeat, especially in left lateral decubitus position. And now, the excessive left ventricular stretching causes decreased stroke volume, decreased forward blood flow, systolic heart failure. And now, the increased left ventricular end diastolic pressure that results to pulmonary congestion and causes dyspnea. So on clinical manifestations, the patient presents with signs and symptoms of heart failure such as dyspnea on exertion, chest pain, and syncope. So when the aortic regurgitation is due to valvular disease, the decrescendo type of diastolic murmur is best heard with diaphragm. The stethoscope is on the left sternal border and at the third and the fourth intercostal spaces, with a patient sitting up, leaning forward, and holding breath in full expiration. So when the aortic regurgitation is due to aortic root disease, it is usually best heard on the right sternal border, and the patient usually has a wide pulse pressure that has the increased systolic blood pressure and the decreased diastolic blood pressure, which greatly contributes to the greater than 60 millimeters of mercury of pulse pressure. collapsing or a water hammer pulse, also known as the Corrigan's pulse. It also brought a brought-up stroke followed by a rapid collapse of the peripheral pulse. A few things to look out for in signs and symptoms includes the Corrigan sign, the Mosset sign, the Quincke's sign, which the capillary pulsation in nail bed, Trowbridge sign, or the pistol shot sound over the femoral arteries, the Austin Flint murmur, the mid-diastolic murmur over the cardiac apex, and the de Rosay sign, which is the compressing of the femoral artery. The diagnosis procedures suitable for the aortic regurgitation includes echocardiography, chest X-ray, cardiac magnetic resonance or CMR, and cardiac catheterization. The treatment for the aortic regurgitation includes loop diuretics, which is to remove the excess fluids and to reduce afterloads. So don't use beta blockers that slow the heart rate down because it is going to increase the time in diastolic and increase regurgitation and steal away the perfusion from the coronary arteries. Surgical management for the aortic regurgitation includes the aortic valve replacement. So here's the nursing management. So one is advise patient to eat heart-healthy diet and maintain a healthy weight. Number 2 is to encourage patient to engage in physical activity. Number 3, advise patient to avoid smoking, manage stress, and control high blood pressure. So, example of nursing diagnosis for aortic regurgitation is decreased cardiac output related to alterations in rate, rhythm, and electrical conduction. So, for the prognosis, 3/4 of patients with significant aortic regurgitation survive 5 years after diagnosis. Half survive for 10 years. Patients with mild to moderate regurgitation survive 10 years in 80 to 95% of the cases. Average survival after the onset of congestive heart failure is less than 2 years. So that's a wrap for aortic regurgitation. So now we're going to tackle the aortic stenosis. Aortic stenosis, or what we call the aortic valve stenosis, occurs when the heart's aortic valve narrows. This narrowing prevents the valve from opening fully, which reduces or blocks blood flow from your heart into the main artery to your body and onward to the rest of your body. When the blood flow through the aortic valve is reduced or blocked, your heart needs to work harder to pump blood to your body. Eventually, this extra work limits the amount of blood it can pump, and this can cause symptoms as well as possibly weaken your heart muscle. So the pathophysiology of the aortic regurgitation may accompany aortic stenosis, and about 60% of patients greater than 60 years old with significant AS also have mitral annular calcification, which may lead to mitral regurgitation. The increased pressure load imposed by aortic stenosis results in compensatory hypertrophy of the left ventricle without cavity enlargement. With time, the ventricle can no longer compensate, causing secondary left ventricle cavity enlargement, reduced ejection fraction, decreased cardiac output, and a misleadingly low gradient across the aortic valve. Patients with other disorders that also cause left ventricle enlargement and reduced EF may generate insufficient flow to fully open a sclerotic valve and have an apparently small valve area even when their AS is not particularly severe, or what we call the pseudo-severe AS. Pseudo-severe AS must be differentiated from low-gradient severe AS because only patients with low-gradient severe AS benefit from valve replacement. Elevated shear stress across the stenosed aortic valve degrades von Willebrand factor multimers. The resulting coagulopathy may cause GI bleeding in patients with angiodysplasia or Hayden syndrome. So there are two types of aortic stenosis, which are the valvular aortic stenosis and the supravalvular aortic stenosis. So the most common causes of valvular type of aortic stenosis in general population is senile calcification of aortic valve, bicuspid aortic valve, and rheumatic heart disease or RHD, where the senile calcification of aortic valve and the bicuspid aortic valve remains the most common causes of aortic stenosis in the Western world, while the rheumatic heart disease is the leading cause in developing nations. So in clinical manifestations, patients presents with cardinal symptoms like chest pain, dyspnea, syncope on exertion, and with delayed diminished type of carotid pulse, the pulsus parvus et tardus, and a single S2 due to delay in A2 component, which leads to overlaps with P2, and results to an audible S4 due to stiff ventricles, which is seen commonly on patients with aortic stenosis. So the high resistance regenerated by the stenosed aortic valve, which leads to resistance, causes to concentric hypertrophy and stiffening of left ventricle, which leads to S4. So a harsh ejection systolic murmur is off to crescendo, the crescendo type, is particularly noticeable at the second right intercostal spaces, which radiates to carotids. The supravalvular aortic stenosis remains the second most common type of aortic stenosis, since the most common type of aortic stenosis is the valvular stenosis. Its etiology is congenital left ventricular outflow obstruction due to diffuse narrowing of the ascending aorta. A systolic murmur is best heard at first right intercostal spaces, in contrast to the valvular aortic stenosis murmur, which is best heard at second right intercostal spaces. A patient with significant supravalvular aortic stenosis can develop to left ventricular hypertrophy, and also some patients associated with coronary artery stenosis can present with symptoms secondary to subendocardial and myocardial ischemia. Patients with aortic stenosis can be asymptomatic generally for a prolonged period. Symptoms typically occur in patients with severe aortic stenosis. And severe aortic stenosis is where the aortic valve area is lesser than 1 centimeter squared. So a classic signs of aortic stenosis, which is pulsus parvus et tardus, a delayed and diminished upstroke, a mid-late peaking systolic murmur from turbulence due to stenosis, and the presence of a soft and single S2 heart sound of a severe aortic stenosis. The thickening and calcification of aortic valve leaflets leads to reduced mobility that causes soft S2. And also, due to reduced mobility and the thickening, it leads to the A2 is being delayed and causes the occurs of simultaneously with closure of pulmonary valve, that is leading to a single S2. So the diagnosis for the aortic stenosis includes echocardiogram, chest x-ray, exercise test or stress tests, cardiac computerized tomography or CT scan, and cardiac MRI, and cardiac catheterization. The treatment or the medical management for aortic stenosis is that treatment for aortic valve stenosis depends on the severity of your condition, whether you experience signs and symptoms, and if your condition is getting worse. If your symptoms are mild, or you aren't experiencing symptoms, your doctor may monitor your condition with regular follow-up appointments. Your doctor may recommend you to make healthy lifestyle changes and take medications to treat symptoms or reduce the risk of complications. No pill can cure or even improve your aortic stenosis, but there are some medications that may help you control your symptoms and lower the chance of having certain complications. So, among the medicines, it could be ACE inhibitors, medicines that tame heart rhythm problems, beta blockers to slow your heart rate, diuretics, so examples are water pills, to lessen the amount of fluid in your body and ease stress on your heart. The surgical management for aortic stenosis includes aortic valve repair. So surgeons rarely repair an aortic valve to treat aortic valve stenosis, and generally, aortic valve stenosis requires aortic valve replacement. To repair an aortic valve, surgeons may separate valve clasps or cusps that have fused. So the nursing management for the aortic stenosis should be assess respiratory status, on lung sounds, on SpO2, on shortness of breath, and sputum, and the nurse should also be a provider of a new or sudden onset of murmurs, especially if accompanied by signs of poor perfusion or pulmonary edema. The nurse should also provide patient education about post-op requirements after valve replacement surgery, such as prophylactic antibiotics prior to any invasive procedures, bleeding precautions, use a soft bristle toothbrush, maintain a good oral hygiene, and avoid dental procedures for 6 months post-op. So an example of nursing diagnosis for aortic stenosis could be decreased cardiac output related to restriction of the blood flow from the left ventricle to the aorta. The prognosis for aortic stenosis, it progresses faster as severity increases, but the wide variability in progression rates requires regular surveillance, particularly in sedentary older patients. In such patients, flow may become significantly compromised without triggering symptoms. A symptomatic patient with severe aortic stenosis and normal systolic function should be reevaluated every 6 months because 3 to 6% will develop symptoms or LVEF impairment every year. The risk of surgery outweighs the survival benefit in asymptomatic patients. So that's aortic stenosis is all about. We've learned that it's the most common and serious valve disease problems. It is also the narrowing of the aortic valve opening. So now we're going to talk about the septal defects. There are two kinds. There are atrial septal defect and the ventricular septal defect. So let's watch this. Atrial septal defect, or ASD, is one of the more commonly recognized congenital cardiac anomalies presenting in adulthood. ASD is characterized by a defect in the interatrial septum, allowing pulmonary venous return from the left atrium to pass directly to the right atrium. Depending on the size of the defect, size of the shunt, and associated anomalies, this can result in a spectrum of disease ranging from no significant cardiac sequelae to right-sided volume overload or pulmonary arterial hypertension and even atrial arrhythmias. So there are 4 etiology or causes of the atrial septal defect. One of them is ostium secundum, which this is a defect that is present at the site of fossa ovalis, and this may be a single or multiple, and it associates with partial anomalous pulmonary venous return, pulmonary valvular stenosis, VSD, pulmonary artery branch stenosis, persistent left superior vena cava, and Holt-Oram syndrome. So the number 2 is ostium primum. It is found in the lower portion of the atrial septum and overlies the mitral and tricuspid valves. It occurs in about 15% of all ASDs and other defects, which includes it affects also with the cleft in the anterior mitral and the septal tricuspid valve leaflets and small ventricular septal defects. Number 3 is sinus venosus. This is most commonly located at the entry of the superior vena cava into the right atrium, and it is rarely at the entry of the inferior vena cava into the right atrium. So it associates on the superior vena cava type is very commonly associated with anomalous drainage of the right upper pulmonary vein, and the inferior vena cava is often associated with anomalous drainage of the right lung into the inferior vena cava, or what we call the scimitar syndrome. The last part of the etiology is coronary sinus. This is a defect in the roof of the coronary sinus which results in direct communication with the left atrium. So there are two types, which is complete unroofing of the CS and partial unroofing of the CS or the coronary sinus. So it also associates with it's commonly with a persistent left superior vena cava. So the pathophysiology of the atrial septal defect starts in the increased left atrial pressure with the oxygenated blood that leads to left to right shunt with no cyanosis. Then next, it causes burden on the right side of the heart. Then it leads to the increasing pulmonary blood flow. Then it leads to the pulmonary stenosis or pulmonary hypertension, which is a type of high blood pressure that affects the arteries in your lungs and the right side of your heart. Then it leads to right ventricular hypertrophy, which is a heart disorder characterized by thickening of the walls of the right ventricle. Then it leads to the final stage, which is the increased right atrial pressure. Clinical manifestations that's being shown on atrial septal defects. So patient could be asymptomatic. The infants, it shows some features of pulmonary overcirculation, recurrent respiratory infections, failure to thrive. On other children, it shows mild fatigue, dyspnea that may worsen with age. So in conducting the physical examination in atrial septal defect, so examination of precordium inspection. So an inspection may occur in the left precordial bulge, and upon palpation, prominent right ventricle impulse is being felt along the lower left sternal border and the subcostal area. So upon auscultation, there's a wide, fixed splitting of the second heart sound, and a systolic ejection murmur is best heard at the left upper sternal border, and the short rumbling and the mid-diastolic murmur is often audible at the lower sternal border. So in diagnosis, we have 4 diagnostic procedures. We have chest x-ray, ECG, echocardiography, and cardiac catheterization. So in chest x-ray, in diagnosing a small shunt across the atrial septal defect can be found. Patients with significant shunts can show cardiomegaly due to right atrial and right ventricular enlargement and increased pulmonary vascular markings extending to the periphery and prominent pulmonary artery segment. In electrocardiogram, it can detect a small left to right shunt and no right atrial or ventricular dilatation, so which means the ECG is normal. The cardiac catheterization and its indications could be if the patient has pulmonary vascular disease and is being suspected, diagnosing associated lesions such as partial anomalous pulmonary venous return or mitral stenosis, and a direct measurement of intracardiac and pulmonary artery pressure can be performed. Pulmonary vascular resistance can be also calculated. Atrial septal defect is a disorder to be addressed surgically or through interventional catheterization. No specific or definitive medical therapy is available. However, patients with significant volume overload or atrial arrhythmias may require specific drug therapy. Surgical management for ASD includes criterion standard. So this is the treatment of ASD, which is the direct closure of the defect by using an open approach with extracorporeal support. Number 2, so this could be a minimally invasive approaches. So this includes partial or full submammary skin incision, hemisternotomy, and limited thoracotomy. Number 3. Percutaneous transcatheter closure. So the secondum ASD have been closed by using a variety of catheter-implanted occlusion devices rather than by a direct surgical closure with cardiopulmonary bypass. These devices are placed through a femoral venous approach and are deployed like an umbrella to seal the septal defect. These devices work best for centrally located secondum defects. The nursing management for ASD would be take the vital signs on the right time, provide rest to decrease oxygen demand, and timely administration of medications. An example of nursing diagnosis for ASD could be activity intolerance related to imbalance between oxygen supply and demand. Prognosis for atrial septal defect. Although life expectancy is not normal for patients with atrial septal defect, patients generally survive into adulthood without surgical or percutaneous intervention, and many patients live to advanced age. However, natural survival beyond age 40 to 50 years is less than 50%, and the attrition rate after 40 years of age is about 6% per year. Advanced pulmonary or hypertension seldom occurs before the third decade. Late complications are stroke and atrial fibrillation. The ventricular septal defect. It happens during pregnancy if the wall that forms between the two ventricles does not fully develop, which leaving a hole. A ventricular septal defect is one type of congenital heart defect. Congenital means present at birth. In a baby without a congenital heart defect, the right side of the heart pumps oxygen-poor blood from the heart to the lungs, and the left side of the heart pumps oxygen-rich blood to the rest of the body. In babies with a ventricular septal defect or VSD, blood often flows from the left ventricle through the ventricular septal defect to the right ventricle and into the lungs. This extra blood being pumped into the lungs forces the heart and lungs to work harder. Over time, if not prepared, this defect can increase the risk for other complications, including heart failure, high blood pressure in the lungs, or also called pulmonary hypertension, irregular heart rhythms, or also called arrhythmia or stroke. There are 4 types of ventricular septal defect where an infant with a VSD can have one or more holes in different places of the septum. There are several names for these holes, so some common locations and names are: number 1 would be conoventricular ventricular septal defect, which in general, this is a hole where portions of the ventricular septum should meet just below the pulmonary and aortic valves. Number 2 is perimembranous ventricular septal defect, which is a hole in the upper section of the ventricular septum. Number 3 is inlet ventricular septal defect, which is a hole in the septum near to where the blood enters the ventricles through the tricuspid and mitral valves. This type of ventricular septal defect also might be a part of another heart defect called an atrioventricular septal defect or AVSD. Number 4 is muscular ventricular septal defect, which is a hole in the lower muscular part of the ventricular septum, and it is the most common type of ventricular septal defect. In etiology, the VSD develops when there is a developmental abnormality or an interruption of the intraventricular septum formation during the complex embryologic heart morphogenesis. VSDs are frequently isolated, however, they can occur in association with other congenital heart defects such as atrial septal defects, patent ductus arteriosus, right aortic arch, and pulmonic stenosis. They are also found in cases of aortic coarctation and subaortic stenosis, and they are a frequent component of complex congenital heart disease such as tetralogy of Fallot and transposition of great arteries. So the pathophysiology of the ventricular septal defect, it starts in systemic to pulmonary circulation and connection, and leads to increased pulmonary blood flow, then leads to endothelial dysfunction and vascular remodeling, smooth muscle cell proliferation, and increase in extracellular matrix and intravascular thrombosis, which causes an increase in pulmonary vascular resistance. Then it leads to the inverted shunt from right to left. Then it leads to, or in the final stage, which is cyanosis or Eisenmenger syndrome, which is a condition that results from abnormal blood circulation caused by a defect in the heart. So most often people with this condition are born with the hole between the two pumping chambers, the left and the right ventricles of the heart, or specifically saying ventricular septal defect. The most common clinical manifestation being shown by the VSD includes shortness of breath, fast breathing, hard breathing, paleness, failure to gain weight, fast heart rate, sweating while feeding, and frequent respiratory infections. The history and physical examination in VSD. So it starts in the presentation of unrepaired VSD is largely dependent on the presence of hemodynamically significant shunt. Hence, it is directly related to the size of the defect. And small VSDs only lead to the minimal left-right shunt without left ventricular fluid overload or pulmonary arterial hypertension. They are usually asymptomatic or found incidentally on physical exam. Medium-sized VSDs result in moderate left ventricular volume overload and absent to mild pulmonary arterial hypertension. They present late in childhood with mild congestive heart failure or CHF. Then those with large defects that develops CHF early in childhood due to the severe LV and overload and severe pulmonary arterial hypertension. The diagnostic procedures being used in VSD includes number 1 is TTE or transthoracic echocardiography, which is the most valuable tool for diagnosis due to its high sensitivity, and it is very useful in detecting any associated aortic insufficiency and other associated congenital heart defects. And it was also helpful in evaluating the right and left ventricular chamber in size and functions. The electrocardiography or ECG is entirely normal in half of the patients with VSD. So when the ECG is abnormal, it may detect LV hypertrophy on those with large shunts, and in patients with pulmonary arterial hypertension, the ECG may show right bundle branch block, right axis deviation, and right ventricular hypertrophy and stain. While on chest radiography or CXR is often normal in those with small defects. Enlarged cardiac silhouette can be observed in those with larger defects and increased LV size. So the right ventricular enlargement and increased pulmonary diameter can be observed in those with pulmonary arterial hypertension. And in cardiac magnetic resonance imaging or MRI and computed tomography CT scan are useful in cases where anatomy is complex, such as VSD is accompanied with other congenital heart anomalies and in defects in unusual locations that are hard to visualize by the conventional TTE. Then we have also the cardiac catheterization, which gives accurate hemodynamic information regarding the pulmonary vascular resistance and response to the vasodilators. And this is particularly useful in those who are being evaluated for surgical closure. It provides more details on coexisting aortic regurgitation in multiple VSDs and when coronary artery disease is suspected. The treatment or the surgical management for the VSD is that it depends on the size of the hole and the problems it might cause. Many ventricular septal defects are small and close on their own. If the hole is small and not causing any symptoms, the doctor will check the infant regularly to ensure that there are no signs of heart failure and that the hole closes on its own. If the hole does not close on its own, if it's very large, further actions might need to be taken. Endocarditis prophylaxis is not needed preoperatively, and it is required only for the first 6 months after repair or if there is a residual effect adjacent to the surgical patch, depending on the size of the hole, symptoms, and the general health of the child. The doctor might recommend either cardiac catheterization or open heart surgery to close the hole and restore normal blood flow. After surgery, the doctor will set up regular follow-up visits to make sure that the ventricular septal defect remains closed. Most children who have a ventricular septal defect that closes either on its own or with surgery live healthy lives. The nursing management being applied here for VSD is that the nurse should be able to assess the patient for signs of infection and maintain aseptic technique during any procedure to avoid any infection, do hand washing before and after procedure or touching the patient. So the rationale behind that would be to avoid cross-contamination and check temperature every 4 hours and SOS. Nursing diagnosis in ventricular septal defect is an example would be high risk for infection related to the presence of surgical wound. Prognosis in VSD is that the prognosis is good for patients who have undergone VSD repair. However, they have a higher risk of arrhythmia, endocarditis, and congestive heart failure or a CHF in the long run in comparison to the general population. So that's it. That's what aortic regurgitation, aortic stenosis, septal defects, which includes atrial septal defect, ventricular septal defect. So I hope you learned something. Thanks for watching. So if you haven't learned something, I recommend you to keep watching this video until you learn something. So that's it. It's a wrap. I'm out.